For cemiplimab, the dosing schedule is actually quite simple. It's given as a 30-minute infusion every 3 weeks. So there's really only one dose that you can give. It's an IV infusion. It doesn't take very long to deliver the medication to the patient. It's a full vial of medication that's delivered in either a 100 milliliter IV bag or maybe 500 milliliters, depending on how the doctor chooses to infuse it. The patient generally doesn't feel much during the infusion. They sometimes may feel something, like maybe this feels a little different, but most of the time the adverse events, if they were going to occur, don't occur until the second, third, or fourth infusion that they have. So as far as the patients go, it's not a huge barrier. They do have to go into a infusion center to have the infusion done, or an oncologist or a dermatologist office that does infusions. So that's one thing. They have to come in. They have to be monitored while they're there, to be carefully watched to make sure they don't have any immune-related adverse events that could occur, like during the infusion. It's possible that the immune system can wake up even during the infusion, and they can have an adverse event that occurs more immediately, but it's more likely that it would occur later. So as far as that being a barrier, coming for the IV, it's a short infusion, so it's not a huge barrier to a patient. So that's kind of nice to see. So what's the response to cemiplimab? So the study showed that the response rate is about 50%. So if you look at all the people that responded partially and all the people that responded all the way or complete responses, that's about half. So I tell people about half the time you'll see a response, and that's a good thing. It's actually much better than some of the older therapies that we had, which that number would be in the 20s or 30s. So it is a better therapy as far as that goes, and that's why it's sort of risen to first line, recommended first line as a treatment for locally advanced and metastatic squamous cell carcinoma. So how does the data that we're seeing in the real world compare to clinical trials? I think would be very similar. I think the trials have continued to show benefit over time. The real world outcomes have been very similar. There hasn't been really any more data published on that since some data was released this summer at a major oncology meeting. So we don't really have more long-term real world data. In my own experience, the patients have done just as well as they have in the trials as far as the outcomes. In a general sense, it's very similar. So it's nice to see that the real world data, and just in my personal experience, matches the trial data. As far as adverse events goes, the serious adverse event rate is actually pretty low. We talked more serious adverse events, maybe in the 1% to 5% range of the patients have the most serious adverse events. Most people that have adverse events are mild to moderate, and they're typically easily managed with simple treatments like systemic cortisone, prednisone, sometimes even a topical steroid, or sometimes they need management by endocrinologist for their thyroid, which can be made abnormal by the treatment. However, an abnormal thyroid test is not necessarily a reason to stop the medication, because that can be managed with other side effects such as diarrhea, or if they have autoimmune pulmonitis, that has to be addressed. They'll have to be addressed seriously. But for severe side effects involving the lungs or the kidneys or the GI tract, the gastrointestinal system, if they're very severe, the patient can't take that medicine anymore. But for thyroid, they continue to take the medicine in some cases, even though their thyroid abnormalities are being managed. So some side effects you can treat through, and other side effects you can't.